Hello. Hello, hello, hello. I am live from my living room. It's not as exciting as my office. If you were there at the live stream yesterday for the town hall around the upcoming conference, I was in my office. That's where I usually am. But fun fact, I'm on the West Coast. This is earlier in the morning. So it's easier for me to just do it at home before I head to the office. But hi, everyone. My name is Chris Tronson. I am a lead advocate for the International OCD Foundation, along with a board member of the IOCDF on the board of directors. I also am vice president and board member of OCD Southern California, and I lead a couple of the IOCDF's special interest groups, such as the Body Dysmorphic Disorder Special Interest Group. I am a licensed therapist here in Orange County, California at the Gateway Institute, and I'm here today just to lead this Ask the Experts. Now, normally I have a partner in crime. I actually love hosting this with somebody. I always see Katie and Ethan host their live stream solo. And I always like they do some stuff. Well, Katie, not always, but more Ethan. And he's so comfortable talking to no one. He interacts with the audience, of course, but I always like to have like a partner in crime next to me. But today I am solo. It is about to be 4th of July. Liz has kids. I don't. She's planning for the holiday. So I'm here just to hang out. I don't want to leave y'all without a live stream this week. But thank you so much for being here for the next hour. Basically, what I'm going to do is we get pre-submitted questions. We have questions from 3 sources. People pre-submit questions. Remember, you can always go to iocdf.org/peace of mind. There's a place where you can ask questions, or you could always kind of just like on social media, hit up the IOCDF social media and ask a question. So you could pre-submit it that way. The second way that we get questions is if in our last stream, if we didn't get to all of the questions, I'm ferociously, constantly saving those questions so that for the next live stream, we could catch up and answer those. And then lastly, live. So this is being broadcast on different social media platforms, including YouTube, Twitch, X, Facebook, etc., and also on iocdf.org/live. So you can ask questions in the chat. We'll pull them up and answer them. So I can answer them from both a clinician's perspective, so being a licensed and trained clinician who's gone through 2 different BTTI, that's the Behavioral Therapy Treatment Institute with the IOCDF, but also just from being trained under great clinicians out here in Los Angeles. And then I have OCD myself. And so I've gone through my own treatment in recovery. And so I can speak a little bit from both angles. So anyways, just super happy to be here. There's always a little bit of housekeeping before we jump in. I already see some live questions, so I'm going to try to get to as many as possible. However, before we jump into questions, I'm just going to take about 5 minutes to talk a little bit about rumination and 3 points that I want people to remember about rumination. So I want to give you a little bit of that, and then we'll jump into questions. Always remember that the live stream is educational. It's not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can always use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. The International OCD Foundation is not a crisis hotline. If you are in a crisis or you're ever feeling suicidal or unsafe, please call the 988 Suicide and Crisis Lifeline by dialing 988 or 988lifeline.org, or go to your local emergency room or call 911. We want to create a safe space and be kind and respectful to everyone. At the end of the day, we're all here to support one another. And once again, a note that this is being broadcast on social media platforms, being recorded. All right, so before I jump into questions, like I said, I already see some live questions. Oh, first and foremost, especially because I'm solo today, remember, you're just as important to these live streams. We talked all about that last night on the town hall, just about community and how important that is. So if you want to make sure to engage, there are people that are going to be making comments throughout the stream. You can always kind of pop in there and answer other people's questions, or you can go ahead and, respond to other people or just give people support. So you're just as important. But what I always like to hear is like, where are you from? So are you from England? Are you from North Dakota? Are you from Canada? Are you from Greece, Norway, Florida, California, Texas, Connecticut, right? Like, let us know where you're coming from. And then secondly, who are you here to support? Are you here for yourself? Are you here because you have OCD or a related disorder and want to get support and help? Or are you here because you have a kid or a loved one, a neighbor, a husband, a partner, a wife that you're here to support as well? So just go ahead and let me know who you're here to support. That's important as well. All right, so what I wanted to jump in before I get into questions is I want to talk a little bit about rumination. So first and foremost, what is rumination? And I'm not going to go super into what is it. I'm going to cover that basis, but I have 3 tips for rumination. Rumination is basically, we all have to remember that OCD has such a behavioral component. We could be checking locks, we could be washing our hands, we could be, sitting down and praying a lot, we could be asking reassurance questions to our friends and to our family. We can be looking up things on Google. We can walk back and forth until it feels right. We can tap. There's all these kind of behavioral things that if people witnessed us doing, they would definitely recognize that, hey, something's going on. But another part of OCD is kind of like why it used to be called, or still is, I guess, the silent disorder. So what you basically can experience is going through your head constantly throughout the day. You may be present in class or at work, but the whole time you're ruminating, you're in your head. So we always want to remember the O is the obsession. So if I walk into class and I have a fear that I may snap, lose it, and harm people in school, that's the O. That's usually in the form of a what if question. I walk into class, obviously we all have seen things on TV where people kind of snap and hurt other people. Maybe we have a family member with anger issues. Maybe one time we kind of lost it when we were younger and hit our sibling. But for whatever reason, we have this fear. It's usually because it's the opposite of who you truly are as a person. I always tell my clients the people that have harm thoughts are usually the nicest, kindest, sweetest people. So you have kind of this fear of, hey, what if I stop becoming the person I truly am and I just sort of snap and harm people? So that's the obsession, the what if question. I think what people forget is the C, the compulsion, can also be mental. So the what if question is about a minute. But if you're spending the entire time in class and after class thinking about, could I harm people? Was I close? That's rumination. That's a compulsion. What we have to learn to do is pull back our contribution to compulsion. Remember, to mental rumination, that's a compulsion. OCD is a monologue. What if you hurt everybody in class? What if you lose it? You're stressed. You didn't sleep well. What if you hurt people? Don't turn OCD into a dialogue back and forth. I did a presentation with a therapist named Shiva Raji, and she talked about this, and I'm going to give her credit. What if OCD is saying, like, what if I end up harming everybody in class? What if I get COVID today and I spread it to my family members? What if God's angry at me? OCD is going to say a lot of things in the form of an O. Our job is to pull back our contribution so it's not a back and forth dialogue all day. So if OCD says, what if I'm going to go to hell? I made some bad choices. If you're sitting there all day, no, I'm not going to go to hell. Yes, you are. Okay, maybe I am. What can I do? You need to pray a lot. Okay, I'll pray after work. That's rumination. You're sort of tuning out the world around you and fixating on answering these questions and collaborating with OCD. We got to pull back our collaboration. This isn't specifically how to stop rumination. We could do another live stream on that, and we have before, but I want people to ask themselves 3 questions that can sort of pause the rumination and help you get out of it as a tool besides the ERP. The first question I want you to ask yourself is, am I in the right mind state to figure out the question I'm currently trying to answer? So what I mean by that is, let's say I just left a plane and I really, really worried that, okay, why I left the plane, I accidentally knocked and injured a kid on my way out. It was busy. It was loud in the plane. I heard crying. What if I just didn't realize, but I just kind of like my knee hit or my luggage hit a kid in the head. The kid's on the plane crying, broken nose, freaking out, and it's my fault. A lot of times people have to ask themselves, am I in the mindset to answer that question? If you're finding yourself panicked, anxious, sweating, frantic, you're wanting to run back on the plane, but you can't because there's, they kind of close it off. The plane's already gone, all that stuff. That is not the time to try to answer that rumination. That is not the time to collaborate with OCD and give OCD our attention. You don't want your Uber driver to be driving in that mind state, and you don't want a dentist to operate on your mouth in that frantic mindset. It is not time to try to answer questions like, am I a killer? Am I going to hell? Am I going to get sick? Am I going to kill my family? When you're that anxious, we go from our rational mind into our panic mind. That is not the place to make decisions. So first question you got to ask yourself, am I in the right mindset? I need to delay this. This is not the time to try to answer these hard questions. And if I do try to answer the questions in this mind state, most likely I will come to the conclusion something's wrong and I will give into compulsions and panic. Second question you can ask yourself is, have I received any new information? Remember, when we watch those cold case, shows that we all like, or those podcasts of true crime, the reason somebody ends up getting caught after 20, 30 years is not because the detective has sat and read the same data over and over and over and gets an aha moment. We see that in the movies. What really happens is that somebody comes forward with new information, somebody comes forward with a confession, they find new DNA evidence, the person ends up telling a family member who reports it to the police. So if you've been ruminating on something for the last 6 days, for instance, right, what you want to ask yourself is, would I spend 6 days on anything else? Well, no, I would only bring it back up if I got new information. So if I was trying to, without OCD, if I was trying to pick between colleges and I've kind of made my choice, I'll move on. The only reason I'd bring up that conversation between the two colleges again, if I suddenly got a letter from this college that said, hey, I understand you picked this college, but we'll give you a full ride scholarship. Now somebody without OCD would bring up the conversation. What we do with OCD is, so let's say I'm afraid I left something on, I went on vacation and I left something at the hotel. If it's 6 days later and I'm still trying to figure out, did I leave something? What did I leave? I'm not going to get an aha moment 6 days later, especially with OCD. The more time you spend on something, the less trust you have in your memory and the more you're confused. It's almost like making a photocopy of a photocopy of a photocopy. So you want to be able to say, you know what? Until a hotel calls me back, until I'm searching for something and can't find it, I have to let it go. I have not received any new information. There is no reason to keep rehashing and compulsively ruminate about the same topic. And then final question you can ask yourself, question number 3 is, has this been helpful? Is this helpful? So in real life, we do things because it's helpful. We go through the drive-through for Starbucks in the morning because it helps us be quicker to work. We charge our phone so that our phone can work. We brush our teeth so we don't get cavities and have problems with our gums. But with OCD, we'll spend a week, a month, 10 years ruminating and trying to figure things out, yet we don't have anything to show for it. We don't have answers. We don't have clarity. We haven't fixed something. We haven't solved anything. So if a client is afraid that their house has mold and wiring that's going to kill them, spending 5 months ruminating about it and not doing anything or not moving on, if you recognize it's OCD completely, it's not going to help you. You don't have any new aha answers, any new clarity just because you spent 5 months thinking. So I want you to ask yourself, has this been helpful? Have I solved the problem? Say you have relationship OCD and trying to figure out if this is the right relationship. Has the last 6 months of being in your head questioning if this is the right relationship answered that question? Are you any more clear? Do you have answers? Do you have something to show for it? If the answer is no, that means that this is not a problem that can be solved through rumination. It may not even be a problem at all, which is 9 out of 10 times what OCD does. But every once in a while, OCD will take a real situation and just amplify it. So maybe you are having some distress in your relationship, but going about it the way you are through OCD rumination is not answering the question. So just to recap, this isn't to solve rumination. That's what the exposure and response prevention is. It's choosing to lean in, pull back compulsions, accept that there are certain things we can know and do and control, and certain things we have to let go of. But what we can do to kind of help us stop ruminating and sort of check, ourselves and move past it is step 1, always ask yourself, am I in the mindset to be in my head trying to figure things out? Step 2, you got to ask yourself, is there any new information? Is there a reason to keep going on this rumination? And then finally asking yourself, has this been helpful? Has it solved anything? Has it worked? If the answer to those questions, if you're not in the right mindset, you don't have new information and you're not getting anything out of it, spending another 6 months on rumination is not going to be that time. OCD gives us that urgency and that feeling like we're just around the corner. We're almost there. We're about this close to figuring it out, but we know that's a lie. And thanks for putting that up, Rachel. So just wanted to give you that. Rumination is a beast, but we do have tools. I hope that was helpful. We have other live streams on rumination. And if you want a whole live stream on rumination, definitely let us know and we can do that as well. So I want to jump in the questions. So the first question, Rachel's on the East Coast. So if you see me doing a little bit of mental math, it's because it's always add 3 hours. So what I see right now at 11:49, Rebecca asks, hello, what do I need to do to become an OCD therapist? It sounds like, she's asking that there's no specified OCD treatment. I guess there's not enough specified OCD was her second question. So yes, we need more OCD therapists. That is 100% true. We need more therapists in general and more mental health practitioners, but definitely more OCD therapists. So if you are interested in becoming an OCD therapist, I'm going to speak what I know of for California and most states. Certain states might have a little bit different, but I believe it's around the same. You want to get a bachelor's degree in a psychological psychological or wow, psychological or sociology. I don't know why words are hard. Major. So that might be like human development, psychology, sociology. So something in that. That does not mean, because there are a lot of people that end up going back to get a master's to be a therapist, that does not mean your bachelor's has to be in those topics. A lot of people got a bachelor's when they're younger in communication or architecture or science. That does not mean you can't then get a master's or you have to quit. Or go back to school rather. It just means you're going to have some prereqs you're going to have to take. But for most people, if you know you want to go into this field, I would take I would get a bachelor's of science or bachelor's of arts, depending on your school's program. In psychology is probably what I'd strongly recommend, or human development or sociology. So one of those subjects. What will happen then is, because you took those subjects, you're going to be able to go straight into a master's. If you didn't, let's say you already got your bachelor's, but it was in a different degree, there'll be some prerequisite classes you'll have to go back and take that you have to finish. Then you're going to apply for a master's degree. Mine was a master's of science and psychology. Some master's programs are masters of arts, or they're different like titles and stuff, but I got mine as a Master of Science in Psychology, and it was very heavy in research, which is why I love research. So you'll enter a master's program that's specifically either for a licensed social clinical worker, a LMFT, which I am, or an LPCC, which I also did that route as well. You're going to go and have about 2 years of classes. And then in your third final year, you might still have some classes, but you're going to do a traineeship where you're going to go to a treatment center and actually start to see clients. And in California, once you get 250 to 750 hours, you then graduate. And then what you have to do is, in California, we have to get 3,000 hours. It's double most states, but you'll work at a treatment center. This is where I recommend working at a treatment center that is specific to OCD, because you're going to get trained, you're going to get supervision. So you work those 3,000 hours or whatever it is. And then once you're that, like myself, you become independently licensed, and you are licensed with a state, and you can see clients. Now, there's a couple other routes. Obviously, you can go the PsyD or the PhD route. Typically, what that means is, instead of going for a master's, my master's program is about 3 years. People go to a PsyD, which I think is about 3 or 4 years as well, or a PhD, which is more like 4 or 5 years. That's going to mean that there's a little bit more heavy research. You're going to probably go to a college and do research there and still see clients. So for people that are a little bit more interested in the research, or that you want to do psychological testing, you can still see clients, but that would be like the PhD route. I just don't like science, didn't want to do that. So the last thing that I'd say is definitely, if you find a therapist like myself or Liz, or find a local OCD therapist, reach out to us. We'll give you kind of step-by-step and some recommendations. So we do need much more people to help. All right, at almost noon your time, at 11:59, C. Quaddy asked, what can you share about inference-based cognitive behavioral therapy for OCD? So inference-based cognitive behavioral therapy, or ICBT, is an inference-based version of cognitive behavioral therapy. So it's a therapy that says that people with OCD make certain inferences. They mistake possibility, imagination, what could happen, for current reality. And I think that that's been a conversation that a lot of us OCD therapists have talked to our clients for many years. I agree with that statement. So most of us with OCD, let's say we're going to travel and we're worried about, okay, what if they lose my luggage, and I'm at this vacation and I don't have my luggage, and then I get sick and my medication's not there, and then I die. And you have this story in your head, you're feeling that going on, and you get so worked up and you get so anxious that you just don't go on your trip, because you mistake that possibility as reality. There's some other components of it, such as like a feared possible self. So this idea, I would say, it's called, if you've heard us talk about core fears, to me, it's pretty similar. So it's this idea that I am afraid that I am somebody who is reckless, and I'm going to hurt other people, and I'm not cautious, and I sort of am somebody that could potentially just consistently harm other people because I'm not careful enough. I don't care enough about people around me. I'm irresponsible. And so the idea is that because I fear that, compulsions are a value of mine, because I need to do these compulsions to prevent me from becoming this bad person. So it's a much more cognitive therapy. What I would say is any cognitive therapy is really good for somebody that is too impulsive. cognitive versions of therapies, whether it's CBT, whether it's ICBT, have a place when a client is just so impulsive, and it helps slow someone down. It helps them start to see, like, this is the origin of my obsessions. This is what's going on in my head. These are these distortions that I have. What I always worry about is people that are too, what I call heady, when they're in their head all the time, sometimes too much cognitive work. They start to use that and ruminate and compulse with it. So what I would say, the best thing I would personally suggest, there's people like myself who are trained in ERP, ICBT, CBT, ACT. I love learning about OCD treatments and blending some of them that I find are really effective together, including aspects of ICBT, of ACT, of DBT. So talk to a therapist that's been trained in different modalities. Ask them, what do they use? I will say, this is my one opinion, and if somebody's watching this who's an ICBT therapist and wants to chastise me, please put in the comment. I love adult discussions, but under the leadership of Sabine Wilhelm, as well as Dr. Sanjay Saxena, I'm very into research. As I said, I have a master's of science, and they put out a statement. So if you go to the IOCDF's website, and maybe Rachel could put it in the chat, they just put out a statement about a month ago that basically, as of right now, ERP, so exposure with response prevention, which is a type of cognitive behavioral therapy, is the most researched, the most studied, and the most effective treatment for individuals with OCD. And I'll add, if you get the right level of care and if you need medication, people get really, really better. I see it with clients all the time. If I didn't think ERP was effective, I wouldn't keep doing it. I don't have a book on ERP. I don't do a training on ERP. ERP doesn't pay me. So I always use what's helpful. Now, sometimes jumping into exposures, people need to slow down. They need cognitive parts. They need motivational interviewing to figure out why they want to get better. So there's so many other components of treatment that are important. So I agree, straight traditional ERP is great for some mild cases. People jump in, they do 6 to 10 sessions and they're better. Other people need a lot more tools. So I think ICBT, like it says on the website, I'm never going to argue with the SCB. I always follow the science, and they've said there's a lot of potential. There's some great research coming out, but as of this time, ERP is still first line treatment. I would caution you, if a therapist comes to you and says, hey, pick which therapy you want. I think we're not there yet. I think that therapists, especially people trained in ICBT or ACT or these other modalities, can absolutely incorporate them in your treatment, and it can be very helpful. But you want to make sure ERP is a part of it. Why? Because people have gone through so much therapy where they've sat in front of a screen or they've sat in an office and talked about things and cognitive things and learned things, and then they leave and they feel great. They leave the office and they go right back to compulsions. What I like to do with clients is, let's go in your environment. Let's go into your room. Let's go to your house. Let's go to the mall. Let's go to the store. And together, let's practice learning. How did you come to this place that this grocery store is contaminated? Let's shop together. What's coming up for you, et cetera. So that's my spiel. Like I said, if there's anybody who loves ICBT, or any clinicians that don't agree with my statements, which I feel are backed in science and on the IOCDF website, like I said, Rachel could put it up. It's under how OCD is treated on the IOCDF website. Then you definitely, but go ahead and comment. I'm always open. Yes. So green tea, guys. So Amy, I love Amy at 1201. So if everybody doesn't know, I'm addicted to green tea. I didn't have mine yet, but I had it for the live stream yesterday. And I think Katie was like, you have so much energy. Green tea is what gets me through the day. And I hear it's good for you. I also, this is super unimportant and random, but I get kidney stones. But I actually got on green tea because my doctor said it helps flush you out. And ever since, I've had so many less kidney stones. I was getting like 13 a year, and now I get 1 a year. If that. So it's awesome. I want to say hi to June, to Cash. Cash has a bromance with Ethan. Ethan's amazing. So excited to see him in a couple weeks at the in-person conference. Gail is from Cape Town. How cool. I've had friends that have gone there and have said it's amazing. A bunch of people are saying, Rebecca is saying I'm an inspiration. You are an inspiration, Rebecca. I think everybody, I did, when I got my hero award, I gave it to everybody with OCD, because I think people with OCD go through so much. I have multiple disorders. I have major depressive disorder, body dysmorphic disorder. I've had panic attacks, all this. I think the one thing that uniquely makes OCD so difficult, OCD and BDD are beasts. OCD turns your own mind against you. It makes you distrust yourself. It makes you distrust what you see and what you feel around you. It makes you distrust your family and friends and research. I mean, I've had people with health related, obsessions. They have doctors and studies and things showing them like, you're okay. Their family and friends are like, you're fine. And the person still doesn't believe everything around. Here's a little nugget of information, and I can't take credit for this either. It actually comes from a 14-year-old client from mine, but we were discussing because she's so smart. And I'm like, how are you getting tricked by OCD again? You're too smart for this. You have some evidence and you have doctors that have told you certain things. You've had your parents that. And she said, but the OCD is so much louder. And what I said to her is, remember, just because somebody's loud doesn't mean they're more right. Just because someone's loud doesn't mean that they're more correct, right? So what I mean by that is OCD is going to be louder because your family and doctors or your priest or whoever you're getting your reassurance from isn't going to scream in your face. That's awkward and not okay. But the OCD screams at you all day. So do not mistake loud for correct. Don't mistake loud for being right. Definitely recognize that just because OCD is loud in your head does not mean it should bypass what you know, what is out there, information, family support system. So I want to say that. All the people saying nice things. June at 12:04 says, I've been accepting my real event. Then I got the thought like, why would I say that? But I just let it pass. So when we talk about acceptance, acceptance is not something unique to OCD treatment. Acceptance comes from certain faiths. Acceptance comes from mindfulness. The idea behind acceptance, what I like to tell people, because I think people get caught up, what does acceptance mean? So if somebody has real event OCD, so that's where something happened in the past. Maybe you went to a couple frat parties when you were younger or college parties. I don't know why I said frat. I wasn't in a frat, but maybe college, right? College parties. And you are at these college parties and everything's great and you don't think about them for 11 years. And then the Me Too movement comes out, or you read an article about, someone that was hazed at a party and taken advantage of. And you start thinking, well, I was at parties like that. I was drunk sometimes at parties like that. I was intimate at parties. Does that mean I was inappropriate with people? Did I not, follow consent? Did I do something that's illegal? Should I be turning myself in? So that's kind of what real event OCD is, where basically something did happen, but we kind of blur our intention or the details, right? And the more we try to figure it out, think about it, all of that, the more blurred it becomes, the less we trust our memory, the less we trust who we are as a person, right? And so what June said is, when she has been accepting or June, I shouldn't assume gender. I'm not sure if it's a male, female, but when June has been accepting and just kind of saying, okay, that event happened. I don't remember the details. It didn't seem to be a big deal back then. The only reason it seems to be a big deal now is because I have OCD and I saw something that I feel is relevant. We do that with OCD. We see something on TV or a story and we attach it to us. So if you're a parent and there's a story about a mom who hurts their kids, it's like, well, could I do it? I'm a parent, I'm a mom. But notice how you never do it with positive things, right? The Olympics are coming around. We don't see somebody, all the gymnastics right now, we don't see them performing and go, aha, I'm going to go in my backyard and do a bunch of backflips because I saw gymnastics. But if we see something bad on TV or a neighbor does something bad, we associate it. So be curious about that. But when June says that they're accepting the real event, what they're basically saying is, I'm going to take a passive approach. I haven't been accepting. I've been researching, thinking, tuning people out, trying to figure things out, punishing myself. But acceptance is simply being passive and saying, you know what? I didn't think about it when that event happened. I didn't think about it for years. Something triggered me and now I can't get off of it. I'm going to let it go. Now, sometimes you'll get that backdoor anxiety, which June got, which OCD says, but why would you say that? But June chose to let that pass. Do not let backdoor anxiety get you. Allegra talked about it on a live stream last week. It's where, let's say you have harm OCD and you get anxious and the therapist and all the articles will say, well, that's why you're not going to harm someone. You're so anxious and worried about it. But then you do treatment, you get better and you have a harm thought and you're not worried, not because you're going to really harm someone, but because you recognize that it's just OCD and you've been getting better. OCD tries to come back and become relevant and again and say, but look, you're super worried. You're not worried anymore. That must mean you're going to harm people. Don't fall for it. And June didn't fall for it. And that's why June's doing great. So I always love when people don't fall for it. Yeah. So Cash at 1206 was saying, I ruminate in advance. My OCD has become future too. So what you want to remember with OCD is always about the past or the future. OCD is never about the here and now, the right now, the present moment. That's why I was heavily trained in mindfulness. You see some of this in the ICBT. Some people use it for ERP, but mindfulness and presence, grounding, etc., is super helpful. I think part of my recovery as an individual with OCD, I got into martial arts after my treatment, and they did a lot of mindfulness and presence. I remember when I would show up to the dojo, they would practice us leaving our problems outside the dojo and come in as like a clear person and focused solely on what we were about to learn. And I started to learn like OCD is never about right now. Nobody ever comes into my office and says, I am dying right now. I'm going to hell right now. I am feeling anxious forever right now. My whole family got sick because of me and are dying right now. It's always like, I did this thing 5 years ago and I think I should go to jail, or I'm so afraid that my kids are going to die because I'm too, reckless and not focused as much, etc. So what I always tell people is like, you're fine. You're chilling right now. You're in an air-conditioned room. You're at work. You're at an office, right? OCD can only be relevant if it's in the past or future. So make sure you stay in the present. It's not always easy. That's why mindfulness is a muscle, just like anything else. You have to learn it. But it's being okay to say, like, right now, everything's okay. I'm worried about a trip, or I'm worried about an event, or I'm worried about traveling, or whatever it is that you're worried about. But right now I'm okay. So I don't need to be as anxious as I would be if this worst case scenario happened. So let me recognize that in the moment I'm safe. And if there really is an issue, because once again, OCD can take on real things, I'll handle it. But this isn't the mind state to be in. But nothing is happening now. Always remember that. Nobody's dealing with it right now. We have Canada in the house. We have England, Puerto Rico. June says they have symptoms of OCD but not diagnosed. Always remember, that's a good question. How do you get diagnosed with OCD? So what you want to do is make sure that you find an OCD specialist. You could find it on iocdf.org/find-help. Find a clinician near you. It can be a psychologist, psychiatrist, a counselor, a therapist. There are different measures. The one that I always personally like is the Yale Brown Obsessive Compulsive Scale Measure, YBOX, both the symptom checklist and severity checklist. But there's a bunch of other assessments you can use. You can actually find them on the IOCF website, and I use those as well. So getting a diagnosis is something that is helpful, just kind of lets you know that, hey, this is why I'm experiencing what I'm experiencing. There's not something wrong with me as a person, just have a mental health condition. So with Burbank in the house. I love Burbank. We have Wisconsin in the house. Houston, Texas. We have a lot of people from all over. We have Lori, who says, I am from Dallas, Texas. I have OCD. I'm also LPC. I work primarily with deaf or hard of hearing clients. I'm fluent in American Sign Language and tried to serve this very underserved population. So Lori, fun fact, I don't always talk about this, but I'm actually about 80% deaf in my right ear. And about 22, I think it was last time I got tested. In my left ear, I have like poor hearing. I actually always have to like sneak so I can get to people, to this side of people, or I read lips. That's how I actually survive. That's why the pandemic was so difficult for me, because I couldn't read people's lips under the mask. So I had to do a lot of like, Luckily I could hear people in sessions, but when I was out. But yes, there are people that are hard of hearing or don't hear. And need help as well. I always think not only do we need more OCD treatment, but we need more OCD treatment for marginalized populations, for disabled populations, for deaf, hard of hearing. We need more clinicians of color. We need more clinicians that speak different languages, more clinicians that are of different faiths. So Lori, you are doing great work, and you're doing great work in a state that's probably really hot right now. So that's even double good. So yeah. June says at 12:09, I have mental compulsions, and when a thought comes, sometimes I say a song or something, but I repeat the thought myself or write it down to give it less power. So one of the tools in exposure and response prevention, or OCD treatment, is to not shy away from certain trigger words or trigger thoughts. I know it sucks. I know it's hard. I had to do my own treatment as well. But what happens is, let's say a word triggers you. We can try to avoid that word, But the problem is you're going to hear it in podcasts, you're going to hear it on TV, you're going to hear it on movies. There's going to be something out in the public that triggers you. So unfortunately, what a lot of people will do is they'll go from like their busy life to stay at home, to stay in their room, to avoid having certain thoughts, to avoid certain words. And that's just not helpful. So what we resist persists. The more we avoid it, the more we push it away. Unfortunately, what starts to happen is we are more afraid of it. It seems to pop up more and more. And secretly, we're kind of scanning for it, right? We're like, I don't want to hear this word or have this thought. And so we're thinking about it more because we're trying not to. And then we hear somebody say it and we freak out. So one of the things that you can do, there's a great tool in Jonathan Grayson's Freedom from OCD book about like writing stuff on sticky notes and putting it around, but it's choosing to bring certain things up on your own. Why do you have to do that, right? Well, because the world's going to bring it up. OCD is going to bring it up. If you bring it up on your own, you get to handle the direction at which it goes. So let's say I had intrusive thoughts where I thought I was going to harm my pet. If I put a picture of my pet as my lock screen is not a pet. Actually, I don't know why my lock screen changed. It's supposed to be of my two little nephews right there. That's what it was supposed to be. But let's say I'm afraid of harming my nephews. If I have this as my lock screen, what's so great is like every time I go to use my phone, I see them. I get to practice response prevention. I'm triggered, I'm starting to have feelings or thoughts about my nephews. And oh my God, what if I hurt them? But I get to practice response prevention and say, oh, that's what you're doing today, OCD. Same old boring song and dance, trying to make me sound like a bad guy. You know what? You could be right, you could be wrong. But the cool thing is I don't have to engage. I don't have to choose to keep talking to you. I can choose to start to label you as the fraud, the phony that you are, and choose to not engage. So you can say 68 things about me and you could be right on 2 or 3, but guess what? If those things happen, I'll deal with it, but I'm not going to deal with it now. So by writing it down, by facing it, by going there, you actually give it less power and it starts to become kind of weak. Rowan at 1209 asks, as an autistic adult with OCD myself, why is it said that autistic folks don't benefit as much from exposure response prevention? What therapies are most effective for OCD treatment for autistic folks? So here's what I usually hear, but you could always correct me, Rowan. What I usually hear from people is not that ERP doesn't work. We actually did a live stream on working with clients that are autistic with OCD. My nephew has autism and OCD. My other young nephew, I have 3. And he's done so well with behavioral interventions. It just seems to make sense for him. He knows, okay, I can't do that. I can't touch that, etc. I think what happens sometimes in the treatment is in ERP at times, therapists can use things that are a little bit more vague, right? So they might say like, well, you have to like, bring the thought in and accept the thought. And like, there's possibility and maybe these things could happen. And sometimes not everyone with autism likes things to be a little bit more like firm, like, is this okay or is this not? And so an example is I was working with a client who was using like a chemical cleaning spray to bathe, which obviously we know that's very dangerous. It was like a Clorox bleach spray thing because in his mind, it was cleaner than traditional soap. And so for him, what was more effective is I brought him from the actual website. You could print something out. It talked about how it was a cancer-causing carcinogen if it gets on your skin. And we talked about that. And I helped kind of educate more cognitive part of the ERP, so the cognitive behavioral therapy component of how he was erroneously thinking, oh, this is cleaner in simplistic terms, but in actuality, this is really unsafe and it's causing me some danger. And then he was more willing to do the behavioral part. So we worked on, pretty immediately, because I was so concerned, transitioning to traditional soap. I find, a lot of times individuals with autism like identify with some of their obsessions more. So, I've had clients with scrupulosity and they read, thou shalt not kill. So they don't want to use sanitizer because they'll kill germs. They're looking down when they walk. They don't want to step on ants. And so somebody with OCD and autism might say like, hey, like, I really want to be someone that doesn't harm. And we have to talk a little bit more about, yes, absolutely. Not harming other people and creatures is great. And you notice how you can't function because of the behaviors from OCD. So I actually love working with clients with autism. I have plenty of clients with autism. I have family members with autism. I love people with autism. And the reason I like working with clients is typically they're very straightforward. We have great conversation. That's what I find a little bit different in treatment is we have a lot more conversations, a lot more cognitive work, but a lot of them have gone through behavioral interventions for autism that has helped them, like my nephew with tantrums and things like that, and how to help soothe. His therapists have taught him how to self-soothe, because before he'd get really worked up in tantrums and breaking things, and now he can kind of self-soothe and calm himself down. So there's a lot of effective behavioral interventions that he's learned, and tools to help him interact with other kids and to self-soothe. And so the behavioral stuff that we've done with him for OCD has worked real well. So what I would strongly suggest is, we've done a lot of live streams. We had one, I think, like during Autism Awareness Month, maybe a month or 2 months ago at this point, because it's July, with Karen Swaney and Dr. Hudak and another guest. And so looking at that, we had a lot of good conversations, and Karen has autism herself and talked about it. So I think it's great. All right. So looking through these questions. Oh, I'm actually going to take a question from the pre-submitted questions. So I'm going to put it in the private chat, and then I'll go back to some live questions. So Rachel's going to put it up, but how is cognitive behavioral therapy supposed to work in order to end OCD? A friend is seeing a psychotherapist, but hasn't really noticed any progress so far, although many weeks have passed. So as someone who's gone through the treatment myself, and somebody who does the treatment on a daily basis, what I have seen in myself, and I've seen everybody else, and why I struggle with other modalities that I feel are incomplete, just like I think there's a need for cognitive interventions in ERP, which can make ERP incomplete. But at the end of the day, people with OCD, yes, we have rumination, we have thought patterns, but we also have a lot of behaviors that we do. And they may sometimes be in the form of avoidances. Sometimes they may be in the form of researching things or reassurance. It's hand washing, it's checking, it's avoiding your pets. It's, looking at certain images of people to check your sexual orientation. So the idea behind cognitive behavioral therapy in general says, hey, if we can change the way we think about things, look at things, our cognitions, and back that up with behavior, we're going to have a different outcome. Now, specifically for OCD, because OCD does have such a behavioral component, exposure with response prevention is saying, hey, you haven't seen your nephews in 3 years and you love them, but you're afraid to see them because you have intrusive thoughts about it. Let's work up collaboratively, slowly, values-based ways, and systematic to get you to a point that you can go spend time with your nephews again. You love your nephews and your nieces, but you've been avoiding them because of what if OCD questions. So what the treatment would work on is, like, what I like to do with clients is, first and foremost, how do we get here? How did you get to a point that you feel like you're harmful to children? That's a pretty bold statement for OCD to make. And if you've had no history of hurting kids, how have you gotten there? And that's where I have discussions with clients, right? They're misreading feelings or sensations or impulses. They've seen something online, or they've read something, or they have a cousin that did something, and they kind of build this story. I always tell clients, like, when they come in and talk to me, I'm like, you're such a nice person, but OCD makes you sound evil. Like, OCD is evil, not you. So it's separating yourself from the disorder. And I feel like there's a lot of good work that way. And a client then becomes more open and understands the point of an exposure, which in this case would be spending time with, their nieces and nephew who they love. And it's practicing dropping those safety behaviors, resisting compulsion. So, when you're there, making sure that you're not constantly like going into the bathroom and checking if you're having sensations, or holding the kid, but holding the kid far away. It's really kind of leaning in, spending time with your nieces and nephews. And that's where you get back to values-based living. You get back to a point that you trust who you are. You start to get clarity about your identity. So it's really beautiful work. And I see a lot of people get better. All the time, I think when people are trying to disprove ERP as a treatment, they're like, well, this research says these people don't get better. And it's like, what are you doing in your practice then? Because I don't have that experience. Other therapists don't have that. So if you find an OCD specialist that eats, breathes, and lives this stuff, and look, it's not just me, it's people like Liz, it's people like all the guests that we have, it's all the great people you see at the conference. We have people get better. So it's really teaching you how to kind of see the world differently, and how to react to the obsessions, changing your relationship with thoughts and feelings. Now, what happens is, a lot of times people will go to an OCD therapist who doesn't really do anything in session. You should be doing things in session, learning things in sessions, having a game plan when you go home in session. So if you're sort of just talking about the OCD, just discussing life, discussing how hard it is, That may give you some temporary relief because you feel validated and heard, which is important as well. Yet you're probably not going to see any change. So what I always tell people is, if you're not going to be cured in 4 weeks, of course, but if in 4 weeks, 6 weeks, 8 weeks of sessions, you have not started to see changes in your life, you're not letting more things go, you're not stopping that rumination, you're not engaging in life, talk to your therapist if you really like them and say, hey, I don't want to tell you how to do your job, but here's what all the research shows, and I'm not doing that. And I'm not getting better. ERP is pretty fast acting. People start to see some recovery pretty quick. So make sure to have a conversation with them, because for some reason, there is, a reason that, they're not doing the work that they should do. A lot of times I just find it's somebody that treats OCD like generalized anxiety and doesn't know what they're doing. Gail says at 12:13, I get compulsions. It's the pits. I had it in shop on Sunday. Tried to ignore it. I could not. I feel like I failed myself and was very anxious. So definitely the reason that I wanted to bring that up is because there are going to be so many times that we it just doesn't go our way. There were so many days in my own treatment where it was just a flop. I tried, I was compulsing, I didn't use my tools, I didn't reach out to my support system, aka my mom. What I had to learn is to give myself some grace. OCD is a nonstop, round the clock, constant disorder. We even have thoughts about it in the shower, when we're driving, when we're dreaming, right? So there are going to be times that you compulse, or times that you give into thoughts, or times where you don't go to that party you wanted to go to, or you wash your hands an extra time, or you do those secret prayers and things like that. What you want to recognize is that we're human. We are trying our best. And I want to give yourself grace. You are all here at a live stream learning stuff about OCD, so you can really practice tools to get better. You're finding community. You're recognizing you have OCD. You're doing so much to try to get better. We all swing and we miss. One thing that used to help me is I think of the days in 4 quarters. You have morning, you have midday, you have the afternoon, you have evening. If you wake up and your morning and your midday is pretty crummy, you still got 2 more quarters in the day to kind of turn it around. Let's say all 4 are not doing great. You can turn it around the next day. So sometimes we need a little huddle with ourselves, or other times we just need to kind of figure out, like, hey, something's not working. Let me connect with my therapist. Let me reach out to my support system. But always remember, you can turn it around, but give yourself some grace. Rowan, yeah, from the conversation that I had, it seems at 12:14, you pretty much got it down. Yeah. Are you in the right state of mind trying to answer the question, right? Don't try to be super anxious and figure things out. If you're spending a lot of time ruminating and you're not getting new information, you're not learning anything, you haven't solved a problem, it's just not helpful. It's being able to move on. Remind yourself that 9 out of 10 times when we're ruminating, there is no problem in the first place, and that's why we can't solve it. Typically, people are ruminating about the past or future. So, if I take my car into an auto body shop, I can't take it in and say, okay, can you fix my bumper? They look at my bumper and they're like, your bumper looks fine. And I'm like, I know, fix it. One day I may get in an accident. It's like, no, when that accident happens, I'll have to take my car in and get it fixed. OCD wants to try to have you predict or prevent things from happening in the future. And we can't always do that. Sometimes we just can't. Things come up and it's a bummer. I run support groups, and one of the members of my support group last night, my adult support group I run Tuesday nights, she was talking about her rumination. She's like, I had a real event happen to my child. Something happened with her child. And she's like, I don't get it. I was like calm, collected. I jumped into action. I did, got my child to the doctors. We figured it out and everything was okay. How come I can be so clear and level-headed in a real emergency, but OCD I can't? Well, that's because a real emergency, we've all known what to do. Call 911, call a doctor, do CPR, find out their allergies. I mean, we pretty much know how to handle most things that are going to go wrong, but we can't predict everything. We can't figure out made up things. We can't figure out future things. So there's so many possibilities that our mind tries to solve in OCD. And that's why we're overwhelmed, stuck, and lost, versus a real danger. We jump into action. We don't even really think about it. And we go into it and we help. So people can handle tough moments and land on their feet and do great in real situations. OCD is the one that gets you. All right. So let's look at some more questions or some more comments. It's so much easier when there's another person, because I could be talking while Liz is looking for the next question. A lot of you are really, really giving each other support. There was a question at 12:20 from June. Would you think writing down thoughts is rumination, or like saying your thoughts, trying to give less power so you're not fearing them? Those are two different things. Sometimes what I try to shy clients away from is making a long list. Like they'll write down all their worries, not as like an exposure, but because they're like, okay, if I write them down, then I won't have to ever worry about them again. And that can be compulsive. But writing them out loud, some people will take their phone and record on like the voice memos and then listen to it back. What you're trying to do is you're getting to a point that, I don't know if you all agree with this, but when we have OCD and we're thinking about something in our heads over and over and over again, it feels real, it feels scary, it feels big, it feels hard. But if instead we kind of say it out loud, we're talking to our therapist about it, we're recording it, we're listening to the phrases or words that trigger us, it takes away the meaning. It starts to become silly. There's a tool from acceptance and commitment therapy, and it's where you pick a word. You start with milk. So you think of milk, you write down, what does milk mean to you? So you're like, okay, it's white, it's creamy, it's cold, it's refreshing. And you say the word milk out loud as quickly as you could say it without it sounding like gobbledygook, right? Milk, 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 milk for a minute. And what most people realize is after a minute, it just sounds like a bunch of mush. The words, you can't tell where it stops and starts, doesn't really have any meaning. You don't even think about milk anymore. It just feels like a word. Try that with a word that triggers you. So, kill, 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 harm, harm, harm. What you'll start to notice is that word loses its power. It's just a word, just like, chicken, just like cheese, just like candy. Obviously, I'm clearly thinking about food. It's just a word. It loses its power. So that's helpful, definitely, for that. Cheese Monster asks at 12:20, is ICVT truly better for themes that deal with content that might not be anywhere near 100% empirically verifiable, like existential or moral type of content? Once again, I'm going to go back to the science. I don't really have a dog in this fight. I've learned both ERP and ICBT. I don't have any trainings. I don't consider myself an ERP therapist or an ICBT therapist. I think there's some people that really love the modality and they sell books on it and they do trainings on it. So they might have a different opinion. Once again, I follow the science. So everything I tell you guys, I think what's so important and what I learned in my Master's of Science program is like, we're all going to have things that we like or don't like or works for someone, right? Like people, like I've sleep apnea, right? A CPAP is kind of frontline treatment for sleep apnea. A lot of people don't use their CPAP. They rip it off in the middle of the night. They can't tolerate it. So there's these other options. There's a mouthpiece you could put in that expands your jaw. Doesn't really work for severe sleep apnea, and it could cause a lot of jaw pain. Some people get an implant. I think it's called like Inspire or something. And it basically, you get this device under your chest. I wouldn't want to go to a doctor and they're like, yeah, first line, you're going to get surgery. We're going to put this thing in your chest and you're going to have this device in you that you have to get removed every 10 years. And then find out that you can just put a mask on at night. And you're like, wait, why? If that's the most research and that's what's working for everyone, why didn't you tell me that, right? Or give people options. It's like, well, you're the expert. What do you think is best? So what I would say is that I don't think that it's better. That's just my opinion. I think what I come back to is the Scientific Clinical Advisory Board of the IOCDF are the top researchers and clinicians on the planet for OCD. They've been doing this longer than most of us, and they have studied and done research and followed the science. So what I think you always want to come back to is, what does that page on the IOCDF really instruct us to do? Let's start with frontline treatments. However, once again, there are eclectic therapists like myself that use different modalities because we find so much strength and helpful tools in those treatments. So this is just my opinion. I get very worried when people abandon a treatment that's working or that is really effective to jump to a new treatment. That's just my opinion. I don't think you have to give up everything. We know a lot of ERP stuff works. Typically, what I find is more helpful is higher level of care. I do an IOP. I've sent people to Liz's residential, and somebody who hasn't had success once a week ERP has gone to a residential or an IOP, and bam, it works along with medication. But definitely read more about it. I saw Rachel put it in there. Spence at 12:21, I like this. This is a question. Patrick McGrath, when he first learned about ACT, realized that he'd been doing those techniques all along. Chris, was that your experience? Yes, I was at a panel for an OCD conference with Kim Quinlan, and somebody asked about rumination-focused ERP, which is something that Dr. Michael Greenberg does. And what we all kind of said, and this is how I feel a lot about ICBT, because I have a high training in mindfulness, and I feel like they borrow a lot from that. Um, is us as therapists, especially those that are out in the field, going to trainings and learning from all of our colleagues that we find are really, really good. You do pick up so many different tools. But when we're working with you in the office, we're not saying, okay, we're going to do this from ERP. Now we're going to move to ACT. Now ICBT. Now traditional CBT. We're working on what works. If I have a client that is in their head all the time, I know getting out of their head, out of the office, and getting them out doing things, it's going to be way more useful. If I have a client that is absolutely refusing to do anything out of the office, I'm not going to drag them out of the office and be like, touch that, do that. I'm going to stay in the office. We're going to do a lot more cognitive techniques, not talk therapy, but CBT. So a lot of it, when I've done certain trainings, there's been a lot of new stuff that I've learned, but there's a lot of stuff, like you said, Spence, that I felt in the different trainings. I'm like, oh, I kind of already do that. Oh, I do that, but I call it something different. What I contributed to probably is because I have OCD. So because I have OCD, there's been a lot of things that I've kind of learned on my own before becoming a therapist. And so a lot of those techniques, I'm like, oh, I've been doing that. So I think that's important. At 12:23, Isostasia asks, is a mental compulsion or intrusive thought, is the treatment different for each one? How can you tell them apart? So what an intrusive thought is like, the reason it feels intrusive is because general thoughts kind of feel like they sort of happen and float on by. But intrusive thoughts feel like they just won't go away. They're hitting us hard. They're usually disturbing. We have a whole emotional experience about it. We find ourselves super, super anxious or worried or freaked out, can't focus. A mental compulsion is what we choose to do with that intrusive thought. So we can't stop having intrusive thoughts. If anybody tells you, hey, the treatment is we're going to learn how to stop intrusive thoughts, they are lying to you. Now, the good news, this is the good news. Please hear this part, because this part's more important. I don't have intrusive thoughts about harm anymore. I don't have intrusive thoughts about incest. I don't have intrusive thoughts about my health. I don't have intrusive thoughts about my mom dying because I didn't do something. You are not going to have intrusive thoughts about your trigger for life. I promise you that if you do the treatment. But what I'm saying is, I don't bring clients in and be like, hey, we're going to learn today how to not have an intrusive thought. Intrusive thoughts are going to happen. That's the O in OCD. Now, what we're learning in treatment is to change your relationship with that intrusive thought. Right now, what we all do in the beginning with OCD is we get an intrusive thought, we listen, we communicate with it, we contribute to it, and then we compulse around it. If I get an intrusive thought that I'm going to push a kid when I'm walking by a busy sidewalk, that's the O in OCD. What if I push that kid? You're going to push that kid, right? That's the intrusive thought. I can't control the O. I can control the C, the mental compulsion. What am I going to do with that thought? I can either turn around, walk away from the kid, go into a store, kind of go in the corner, freak out, have my mom come pick me up. Well, at my age, that'd be weird, but have my mom come pick me up and not go in public. That's the compulsion or mental compulsion. I can review. Why did I have that thought? What kind of person has that thought? Am I a bad person? Am I disgusting? Who has these thoughts? I should punish myself. Or I can simply say, there's OCD again. I'm going to walk right next to that kid and come on, bring it on, OCD. Let's see. Either I'm going to push the kid and you're right, or nothing's going to happen. And guess what? You walk by that kid and the next kid and 15 more kids and nothing happens. And then you sit down with your therapist and you're like, hey, I went out in public. I was walking down the street like normal. I was next to kids. I was next to busy streets and nothing happened. And it's like, oh, what can you conclude from that? OCD's lying. I don't push people in the streets. OCD made that up. It's something that I worried about for so long, but when I actually faced it, it's not coming true. That's the power of learning. That's what learning is in treatment for sure. All right. I'm looking at the time, so I'm going to try to, whatever the next question will be, the final question. And then what I always do is after this, I always scan through all the questions that I didn't get and then put them on our list. So, okay, perfect. So Jane Taylor asks, I'm dealing with depression, OCD. Can you recommend books that deal with this? So what I would look at, Jane Taylor, is one of those two things, right? I would look at, first and foremost, is the OCD is the depression rather caused by the OCD? If the depression is caused by the OCD, you still want to work on the depression. So one thing that we do for depression is we do behavioral activation. OCD slows us down and quiets us down, and it kind of wants us to just lay around, disengage with things that we're passionate about, lay in bed all day, write, close the blind. So behavioral activation is getting out, it's getting engaged in things that we like, getting some vitamin D, being around people, having stimuli, right? But most people's depression clears up when they get OCD treatment. However, you may have a separate experience with depression. Maybe a family member. I was just going to thank you, Rachel. That's what I was going to point Jane to. Maybe you are experiencing separate depression, right? Maybe it's around grief. You lost a family member and you're finding yourself depressed because of the grief. Maybe it's a medication. You need medication for the depression. It has nothing to do with OCD. So what I'd first and foremost do is definitely talk to a psychiatrist and kind of see the source of the depression. I have so many clients with depression that clears up on its own with OCD. I would go to the book list that Rachel just put up. So iocdf.org/books. But some of the books that I like for OCD that do also, touch on the depression that you have, I really like John Hirschfield's books. He has the Mindfulness OCD workbook, but he has a collection of books. So I definitely think that those are great. I also like the OG. It's Dr. Bruce Hyman's, the OCD workbook. So check those out, but go to that website and look. There's a book that I really like for depression. It's called Out of the Blue. And so it's a book on the things that you can do outside of medication for depression. I do think that medication helps a lot. I took depression for my depression, but this book comes up with some strategies that you can do outside of it. So cognitive behavioral therapy can work for depression, behavioral activation, engaging with people, getting connections, getting back into things that you value. Getting a pet can really, really help you. Volunteering, giving back, all of that can help. Real quick, at 12:29, Alex, she wrote, says OCD loves to go into the archives. Absolutely. OCD is going to go back to archives of things you said, things you did, things you read, things you watched, things you heard, and use that against you. So don't be fooled or bamboozled by it. So, and I like what Amy said at 12:30. Acceptance doesn't equal approval. Acceptance is not accepting that you're a pedophile, that you're a killer, that you're a bad person. No, 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 no. I accept that I pay taxes and live in a state that has a lot of traffic. That does not mean I like either of those things. So always remember, acceptance is a passive action. It's saying, you know what? This isn't worth my time. I'm letting it go. That's all it is. There's a really good, I don't even know how to put images up here, but there's a really good image, and it's a split screen, and it's a picture of it raining. And it's a person saying, no, it can't rain. Today's an important day. It shouldn't rain. Oh, it's ruining my day. I wish it was sunny. Why does it have to rain? And then in the second image, it's raining and it just says, yep. And that's what acceptance is. You have plans to go to the beach. You can hate the day, be mad at the world, and spend the next 10 hours mad that it's raining and you're not at the beach and you've ruined your day. Or you can look out and say, all right, it's raining. I'm going to hit my friends up. We're going to go to the movies instead. We'll go to the beach when it's not raining. Doesn't mean I like that it's raining. It just means that I accept that it is and I pivot. All right. For everyone whose questions I didn't get to, I'm going to stay on after this live goes off and copy and paste to the top of our questions list. That way, when Liz and I come back and are answering your questions, I believe in 2 weeks, because next week is the 10th, which is a research roundtable. But Liz and I will be back on the 17th, the week before the conference, and we will answer any questions that together that weren't answered today. But thank you so much for your time. Thank you for hanging out. And as always, go to the iocdf.org website. There's so much information. There's questions on ICBT, questions on ACT, questions on ERP, on acceptance, on intrusive thoughts. There's so much good information out there. Make sure you head out there and read for yourself, learn for yourself, and see really what you are interested. The last thing I, of course, want to say is we are going to have our annual conference, the 29th annual conference. It's an amazing opportunity for the entire OCD community to come together. We did a great live stream on that last night. So you can register today on iocdf.org/OCDCon. That is the weekend of July 26th. So you can register and join us in Orlando. If you cannot make it in person, great news, there's a virtual component. So you can actually be watching the presentations in real time. So make sure you check out the virtual option as well. Don't forget to subscribe on whatever platform that you are hanging out with us on. So definitely YouTube, Twitch, Facebook, and then you can always watch these lives back, either youtube.com/IOCDF, or if you go under Facebook videos, you can watch them back as well. Don't forget to donate at iocdf.com org/donate. We're a nonprofit and you help support us. Next week, Ethan will be back. I believe it's Ethan or maybe Katie for Community Conversations, Tuesday, July 9th at 7 p.m. Eastern. And then Research Roundtable will be noon, same time as today, next Wednesday. And then I will see you with Liz in 2 weeks. But anyways, it's been great to hang out with y'all. Take care. Kick OCD's butt. It's a liar. It's not your friend. Trust yourself, and have a great rest of your day. Bye.